Sorry about that. So what are the key parameters to consider when you want to evaluate CGM devices? Okay, so of course, our other speakers have talked about when you would use CGM. And I just want to say that the number of CGM devices registered in Singapore is very low. Don't bother to do this, because actually what I'm going to say is that because Singapore, like India, is a very porous place, what is registered to your local health authority is not necessarily what people will pick up on the internet through I don't know what, Lazada. I'm not sure what your internet platforms are like, right? So your patient shows up in your hospital or in your clinic, he's got his own brand, right? It's a cheap brand, he got it on a special, and you wonder, can I use this? How am I going to use this, right? Am I responsible if my patient uses this and he goes to the hospital and the house officer gives insulin based on the number that he had, all right? So there is difficulty with regulating access to registered CGMS devices alone. You can't block the access. So actually, what do doctors need to know to be able to assess whether a given brand is good or bad? You cannot be just, oh no, you only use the established brands because the established brands are good. Is that really true? Should you not give a choice to people? Maybe the cheaper brand's just as good. On the other hand, you don't want to be stuck with the medical responsibility for somebody using a brand that gets him into trouble, and your medical director looks at you and says, well, why did you use this? How did you allow this technology to be used? We need to actually navigate our responsibilities and be able to understand to what extent you are responsible, to what extent you have to let the patient respect his choice and help him on his journey. We need to educate and moderate expectations with regard to CGMS and pumps. You need to tell the consumers and healthcare providers between the differences between certain highly specified CGM systems. We call them ICGMS, or integrated CGM systems, and that are actually certified for use with insulin pumps. Actually, there are only about 3 or 4 brands that are actually certified. And surprise, surprise, not even all American brands are certified to this standard. On the other hand, most CGMs are certified for adjunct use. In other words, it's to help you tell trends, and if you get a funny looking number, please confirm with a finger prick. Now, on the other hand, all devices may fail prematurely or have accuracy issues due to batch variation, or because that little shipment that went to your town was on the back of this guy's truck, and this guy was stuck in a 4-hour traffic jam in 45-degree Delhi heat, right? And that is going to change the accuracy. So it is important to always tell our patients, please test with a finger prick if in doubt at this stage of the game, right? So which patients are most vulnerable to tech malfunctions? Obviously, the type 1 diabetes patients, especially those on AID pumps. So this group that are on AID pumps, maybe you have to tell them, look, you have paid this much money for an AID pump, be a bit careful about what CGM you're going to use. But you have to understand that this risk is present even when people are using expensive brands. The other group that is actually a bit vulnerable to wrong interpretation of data are the patients type 1 or type 2 who are relying on CGMS data for insulin dosing. And also because of the women with gestational diabetes who might be using this to control their diets quite a lot. On the other hand, you've got the people who have just been told that they might be at risk for pre-diabetes, the ones who are on ketogenic diets, the ones who are training for half marathons, and who are wanting to know a little bit more about their health. So those people are actually looking at trends rather than actually actionable things. If you eat a box of chocolates and your sugar goes high, okay, I know next time I don't eat the box of chocolates. But if I'm going to be dosing insulin based on that number, then you have to be careful about what that number does and does not tell you. So you can actually realize that problems with CGM are common. This is a study of 99 adults in Washington University in the US. Majority of these guys were type 1 diabetes, and about 2/3 of them were on pumps. If you looked at the experience, about 35% of these guys had a problem with device malfunction or disruption over the course of a year. 18% of them would have had insertion problems, and many of them also had sensor attachment issues. In other words, the thing drops off prematurely. In our climate, of course, these things will drop off prematurely as well, or function shorter than their intended time. And the other thing that you also have is that it may be accurate, but not for the total number of days that they claim it's going to be accurate for. Sometimes they say 14 days, and you find that the accuracy drops off after about 7, 10, or 11 days. And while the sophisticated users will come back and give you this feedback, you must be careful to tell the people who are maybe not so sophisticated that these things can occur, and that if towards the end of or towards the second half of the stated use time, they start to see funny looking numbers, maybe it's time to just change the sensor. Okay, we talked about expensive versus cheaper brands, and I just want to point out, without really wanting to point figures, that major manufacturers are not spared. If you look at news reports from the last few months, you'll find that Abbott, Medtronic, Dexcom, all these major brands, integrated CGMs manufacturers, all have had their QC problems. Deaths have been reported. Major problems have been reported with people on hybrid closed-loop pump systems. So you just have to say that as a product category, this is not perfect yet, right? It's not perfect. Just bear that in mind. Okay, I just want to talk a little bit about EU certification, because in the Singapore market, in many markets in Asia, we look to it and say, oh, if it's EU, it's got the EU mark, at least it must have been passed. So what about this EU mark? EU marked CGMs have gone through a process, and this process is supposed to have had something called a quality management system, where they are supposed to have evaluated data, evaluated studies, and a responsible body in the country where it's registered or first applied for registration is supposed to have gone through the data. One of the problems that we have around the world in many jurisdictions is that because this is such new technology, the regulators may not really know how to regulate, right? So if we, the doctors, the experts, are struggling to deal with the metrics and to interpret the metrics, you've got to think the people who are supposed to regulate and talk about quality, sometimes they don't really know. They might actually be fed data from the manufacturer, and they just accept that data because they don't really know. So in fact, this is what happened in Europe. In 2025, IDF Europe took a position that some CE marked CGMS products were not fit for purpose, even though they were approved for use in the EU through the Conformity European or CE mark system. So case turned up in Italy over poor accuracy of CGM devices at low or high glucose extreme readings. In 2024, there was a problem with UK, which is a brand of a pump with integrated CGMs. The manufacturer made both. And in Portugal, just last year, the national authority suspended the use of a closed loop system because it had the manufacturer's CGM that was supposed to work with this pump had a high MARD, or rather poor inaccuracy. So why might a CE marked CGMS still not be good enough? Well, the problem is, although there is supposed to be a process, there's currently no device-specific guidance in the EU detailing the necessary criteria for assessing CGMs based on accuracy, reliability, and effectiveness. That's real-world data. And the absence of standardized CGM-specific evaluation criteria means that the manufacturers are working blind, the regulators are working a little bit blind. what should be the key features of a quality CGMS? Clinical data must demonstrate accuracy for the intended use population. Now, when you saw one of my earlier slides on the number of devices registered in the Singapore market, and many of them said registered for 2 years and above, I will tell you that my colleagues in Singapore, many of us were worried because we said, where is the data from these manufacturers actually detailing that it had been tested in children 2 years and above, or for that matter, in gestational diabetes, right? So in a cowboy market, you as the doctors have to be better policemen than the police, as it were. The performance must be based on clinical data obtained from studies in the intended use population throughout the measuring range of the CGM and throughout the sensor wear period. In other words, if it says it lasts 14 days, 10 days, 15 days, is it accurate from day 1 to day 15? Or is it only accurate from day 2 to day 10? Or from day whatever to day 7? This is very important because in many of these products, the first day is very inaccurate. The first day data is very, very inaccurate. Okay? There should be good data in the presence even of potential interfering substances. And just now, our first speaker was talking about this in the Australian context, where it's important. But the Australians are actually quite a sophisticated CGMS using population. So they know these things, they're looking out for these things. Our patients, our hospitals may not be so aware. There should be no gaps in the sensor data that would prevent connected devices to function. These would be the hybrid closed-loop pumps. But data transmission should give you real-time glucose readings at clinically meaningful time intervals. Now, what does that mean? Because you've got a sensor lag time, okay? If you actually take readings at very long intervals, right, you'll get beautiful graphs, but those readings will be 5-10 minutes out of date. Okay? So you know that you've got all these little sensors, the battery's only this size. If you have readings every minute, the battery can last only so long. You want to make this sensor last longer, you have readings every 3 minutes, every 5 minutes. So read carefully. So sometimes when a sensor says, my manufacturer says, my product can last 10 days, 15 days, however many days, ask the next question. So how many times a minute or 5 minutes is it actually going to give me a reading? All right? So again, depending on what you're looking for. Type 2 diabetes, the worried well, doesn't matter. ICU setting, hospital setting, AID pump setting, maybe it matters a lot. Okay, so we also know that for many, actually earlier generations of CGMS, people tried to reset the thing so that it could last longer. And actually, we know that means the second wear period, you're going to get very inaccurate data. If you're going to use that inaccurate data to give insulin, good luck to you, right? So who needs to step up to the call for accurate CGMS? Doctors who are familiar with CGM should take up the call. And we know many of our colleagues are not very, very knowledgeable about this. The fact that you guys turned up here and I'm listening to me, even though I'm preventing you from having lunch, you have got some interest in it. But even for myself, it took me a long time because when we first used CGM, there were only 1 or 2 manufacturers on the market and we took whatever we got. But now that there are more manufacturers on the market, we have to learn and be familiar with the technology to know the pros and cons, right? Okay, so we have to also make sure that our national patients associations and the doctors associations step up. Consumer rights groups, patient supports groups, they need to step up. But how can they step up unless they know what they're looking for? So we should not reinvent the wheel. Just take this particular slide if you want to. I just want to point out that there are publications out there from consumer rights groups telling you what to look out for, how to actually interpret data that is put out by manufacturers, right? For example, if you're wanting to sell this for type 1 diabetes patients, make sure the data comes from type 1 diabetes patients. Make sure that the data doesn't come from just an OGTT, all right? Because we know that if you've got a very slow changing glucose level in the patient, it's easier to be accurate. If you've got a type 1 patient who's got very rapidly changing glucose levels, there can be sensor lag. Okay, so we need to teach patients about the jargon. We need to teach doctors about the jargon. We need to teach them little tricks like, did you include first day data or do you only include from second day onwards? So our August senior colleagues, you'll see V. Mohan's name in there. Some of these guys are working at international level to go and set up higher standards. But we on the ground need to understand that there are many ways to fix an MARD to give you nice looking numbers, in the same way that you can actually fix the way that you get economy figures for petrol consumption in a car, right? You can also fix MARDs. Today, I'm not going to talk about the details, but there are ways to fix this. If you don't understand this and you just look at a table that tells you all the various different features of the different CGMs on the market, right? You might be taken in by the fact, oh, this one lasts 10 days, this lasts 7 days, this lasts 14 days, without actually asking about accuracy and how they arrived at the accuracy figures. Okay, so for example, this is what we're looking for. This is less jargon. Take this picture if you want to. Okay, you might also remember that independent studies may show different results to manufacturers' claims. So the green one is one recent available Chinese study, Chinese brand. You can see that there's quite a lot of variability depending on which day you took the results. And if you don't do the test, your rivals can do it for you. So this is a study of a Chinese brand. The authors actually are from Abbott and Freestyle. Okay, so your rivals can actually do the test and show you that you look bad. But before we talk about people looking bad, just remember, 10 years ago, how did Dexcom G4 and the Medtronics and Light perform? And I want to point out to you that their MARDs were also in the 10 to 20% range, right? So if our patients are now able to use stuff which is less accurate than the top models on the market, but they were the top models, but they were the best we would get 10 years ago, is it so bad to actually start our patients on affordable therapy now? So if the regulators don't do this, there are other people who do this. So this is an interesting guy, private individual. He put 9 sensors on himself and did comparative studies, right? And to take a look at the MARDs. And actually, since this is in detail, and interestingly enough, actually some of the new players didn't perform badly compared to the old players. Right? So this is consensus error grid data, again showing that on a one-on-one basis, right? N of 1, but 9 sensors on the same guy at the same time, and all on the same part of the body. Some of the new players didn't do badly. Okay? But some sensors always tend to overread, and this is called bias. Some sensors may be less accurate at high levels or low levels, hypoglycemia, and you need to then decide, are you working in a neonatal ICU, you're looking for hypoglycemia, or are you looking for hyperglycemia? Just know your product, okay? You also have to bear in mind that the failure rate changes from place to place. So it's a brave new world for tech in Asia, in India as well. CGMS, you have to balance the risks and benefits and affordability. Is it to aid treatment? Is it to aid learning? And are we using whatever our patients can afford, or are we just trying to impose our will and saying, you can't afford the best, don't bother to use it? Okay, I want to stop here. Thank you very much.